Well, good evening, everyone. Thank you for coming tonight to hear some great speakers to our Premier Health Restoring Function, Restoring Hope, the Evolution of Head and Neck Oncology. I would like to do some quick introductions before we get started on our panel who's going to be speaking tonight. We have Dr. Kazim Alwani, who will be speaking tonight. We have Dr. Sameep Kadakia, who will also be speaking tonight. My name is Laura Scalise. I am the System Director of the Oncology program, so it's nice to see everyone tonight. We also have on the call for the panel Amanda Musser, who is the Vice President of the System Vice President of our service line for oncology. So if you go to the next slide, I'd like to tell you a little bit about our Premier Health Head and Neck Oncology and Reconstructive program. And then I'll get into some of the housekeeping items before we kick off with our presenter. But we have a packed presentation tonight of great information for the group. And again, we really thank everyone for joining us tonight. So regarding Premier Health Head and Neck Oncology and Reconstructive program, we offer the first and only comprehensive head and neck oncology program in the Dayton region to patients here, right here in the Dayton community, right here close to home. They don't have to go out of the network and out of the area. Our highly skilled team provides a full spectrum of multi-specialty care for all types of benign and malignant head and neck tumors, as well as skin cancer in the head and neck. So reconstructive plastic surgery in the head and neck area include procedures following cancer surgery and treat skin cancer wounds, trauma and radiation related wounds. The scope of the Premier Health and Oncology services range, of course, from diagnosis to treatment, and all the surgical types of procedures, including the new single port robot, to rehab, recovery, supportive care cancer services, and reconstructive surgery. Next slide, please. So here's our two speakers that you see on the screen here with the new single port robot. I love this photo. So you'll be hearing a lot about that from Dr. Kazim Alwani. But there is a full comprehensive coordinated care with this team. The care of the patients referred to this program, they really maintain a multidisciplinary interdepartment collaboration with all required specialties. It really is a team approach and it's very comprehensive. We provide referring physicians' patients timely scheduling to get them on the road to recovery and restored function. And through clear, consistent communication, our head and neck cancer specialists keep the referring physicians up to date on their patients' care because it is very comprehensive. Next slide, please. So our first speaker, Dr. Kazim Alwani, is going to be talking about surgical treatment of oropharyngeal cancer. And before we kick him off, and I would like to introduce him, but we want to remind everyone, as you are listening to the presentations, there is a Q&A button at the bottom of the screen that you should see. If you'd like to place some questions as you're listening to the presentations into the Q&A, Amanda Musser at the end will be actually providing and facilitating that question and answers with the two specialists. So if you have any questions, please feel free to go ahead and put that in there, and we would really appreciate that. For those questions that we don't get to at the end, we will be following up with those answers with you at a later time. So just wanted to make sure that you had that information. Next slide, please. So let me introduce Dr. Kazim Alwani. He is the Premier Health Cancer. He was brought on, let's see, it's been over a year now. He's fellowship trained in advanced head and neck oncologic and microvascular reconstruction surgery from the University of Texas Southwestern Medical Center in Dallas. medical degree from Kilimanjaro Medical University in Tanzania, residency training at the Indiana University in Indianapolis. So he's from the Midwest region here, and trained in transoral robotic surgery, algorithmic facial nerve reanimation, airway reconstruction, advanced open skull base surgery. He performs the full gamut of reconstruction surgery, as you can see. He's also the associate professor at Wright State University Boonshoft School of Medicine, Department of Reconstructive Plastics and Reconstruction Surgery. So with that, I would like to turn it over and welcome Dr. Kazim Alwani, who will provide you with lots of great information. So Dr. Alwani?
Thanks, Lori. And can you hear me okay, Lori?
Yes.
Good. Just a quick correction there. I'm still assistant professor, not associate. That's a rank reserved for my dear friend and partner, Dr. Kadakia. But we can go to the next slide, please. Thank you for that introduction, Lori. So we'll be talking about, at least my segment, about the surgical management of oropharyngeal cancer, and with specific emphasis on how we utilize robotic surgery and what our oropharyngeal cancer program looks like here at Miami Valley Hospital. And the reason I picked the oropharynx is because, you know, the oropharynx right now, oropharynx cancer is synonymous with HPV-related head and neck cancer. There's different numbers being thrown out there, but about 80% of new head and neck cancers are HPV related. And so there's papers that are showing that the face of head and neck cancer is essentially changing right now. And so it's a matter of pride and privilege that we have an oropharyngeal cancer program here at the Valley that is comprehensive, and that we can take care of our patients without them having to go anywhere else, but and stay within the community. Next slide, please. So we'll talk about history of oropharyngeal cancer and what we did for it, the epidemiology, the indications, and there's a lot to go over, and there's lots of data and lots of graphs. But if you are to, you know, lend me your ears and listen to the highlights that I have to offer, I promise you it will make sense. And the picture on the top left is typically what you see with the smoking, alcohol related oropharynx cancer. It's an ulcerated, angry-looking, large mass inside the mouth, and then you have small lymph nodes. But HPV-related oropharynx cancer is a little different. It looks like what's on the left bottom picture, where you have this plump tonsil, and typically these patients come in with a very large neck mass. They're usually healthy accountants who and engineers who are shaving one day, and they find a bump in their neck, and next thing you know is they have oropharynx cancer. And when we talk about oropharynx, we really mean the palatine tonsils, the lingual tonsils, and things in the back of the mouth that you can see when you say ah. Next slide, please. And this is sort of how we started. Back in the 1900s, 1950s, we did open surgery for this. We still do that, but those surgeries, they were poor outcomes, carried a lot of morbidity. Somewhere around 1950, we started using old school radiation, and you know, the outcomes were not that great, but it was less morbidity compared to the open surgery, so that became popular. And then radiation technology improved, and we started doing IMRT, and then we introduced chemotherapy to things, and ultimately those outcomes looked wonderful. And now we're sort of in the era where we have you know, laser surgery and transoral robotic surgery, which has again started to become a little more common and mainstay. So oropharynx management has seen some changes as time has progressed. Next. So these are some of those open techniques that we talked about that we used to do as standard of care historically. Now they're reserved for very specific cases. And you can see the left one where we pull the tongue out through the neck, or the middle picture where we split the jawbone and you know, work swing the tongue to one side and then get back there to be able to cut out a tumor or go from the side, as you can see on the last picture. But things have changed. Next slide. And again, next. So there's about 700,000 cancers, head and neck cancers, that are diagnosed globally, of which 120,000 are in the US. Half of these, about half, are in the oropharynx. And so that's a high burden of disease at this one head and neck cancer subsite. We can go to the next slide. And really today you'll hear a lot about HPV, and this is the reason why. It's because if you look at figure A, HPV-related cervical cancers have been declining, whereas HPV-related oropharynx cancers have been on the increase, to the point that HPV-related oropharynx cancers are now more common than HPV-related cervical cancer. And that's really testament to public health campaigns where women were vaccinated against HPV when we realized that HPV caused cervical cancer, but we haven't done so in the male population, and therefore a large portion of the HPV-related oropharynx cancers happen in males. The good news, though, is that if it is an HPV-related oropharynx cancer, there is a higher risk of, a higher chance of survival rather than in an HPV-negative head and neck cancer, which is what is caused by alcohol and smoking. Next slide. So even inside or within the head and neck, you can sort of look at figures C and D. What these are showing is that as oropharynx cancers increase in incidence, the incidence of oral cavity cancers, larynx cancers, other cancers in the head and neck have been decreasing. Again, a testament to public health campaigns, because we campaigned against smoking and heavy drinking, and we've seen sort of those efforts come to fruition. But unfortunately, HPV oropharynx cancer went completely missed, and there's an entire generation or 2 generations of folks out there that are very much at risk for this. At present time, kids are getting vaccinated against HPV, but young adults, middle-aged folks have all been missed. So the risk remains really high, and we're still seeing an increase in the prevalence as well as the incidence of HPV-related head and neck cancer. Next slide. And we've been saying HPV, but what HPV really is, it's a DNA virus, and there's different strands. And we all know that 16, 18, 31, 33, these are the high-risk subtypes that are related to cervical cancer, anorectal cancer, and oropharyngeal cancer. Type 6 and 11, that's what causes warts, that's what causes respiratory papillomatosis. These are benign disease, they're nuisances, but ultimately they're not, they don't have malignant potential. Next slide. And if we look back, really, I think it was Harold Howson who identified HPV's potential in causing cancer. And this was for cervical cancer. And this was 1970s, 1980s. He just won a Nobel Prize in medicine and physiology, I believe, in 2007, 2008, somewhere there. So it took 40 years for that Nobel Prize to come through. Gillison is the one who pioneered the role or the causal link between HPV and oropharynx cancer in the head and the neck. She was at Hopkins, and now she's at MD Anderson. So I'm waiting for when she wins a Nobel Prize for her work. So it's in the making, but she was the one who pieced it together. Next slide. And next slide. So the ultimate question is, when do you do what? We know that HPV causes oropharynx cancer. We've talked about the tonsil mass, the back of the tongue mass coming in with a large neck mass. Now we know that these patients, a lot of people are at risk. These are mainly males, but females are certainly included in that group. So what do we do about it? And when you look at the NCCN guidelines, this is what you see. Basically, what this means to me is you can do anything. Anything works. If you look hard enough, you can find a reason to justify a particular modality of care. Next slide. But as surgeons, when when in doubt, cut it out. That's sort of the motto that we live by. And but it's not as simple as that. And that's why we at the Valley Hospital have a very fruitful and a very collaborative tumor board where we discuss the nuances of how we manage things. But ultimately, early stage disease, you can go with surgery or radiation. If it's late stage disease, there's some sort of multimodality therapy that is necessary, whether that's surgery followed by adjuvant treatment or upfront chemoradiation. Next slide. And so let's look at those different modalities of care. And this sort of paints a little bit of a historic picture through data. And I'm not going to belabor all these graphs. There's certain main points here that we need to talk about. And this is a study that was extrapolated from the SEER database. Their SEER database actually banks histologic tissue that people looked at in retrospect. And what they found was cervical cancer is decreasing. One, we know that oropharyngeal cancer is on the uptick. But when managed with just radiation, compared to when we add chemotherapy to radiation, overall survival was great. This was published in the 90s, and these were mainly HPV negative patients. I think the survival rate that they published was about around 50%, which was good, but patients had some mucositis, some G-tube dependence, and there were late effects from the radiation. And this was for HPV negative patients. Next slide. And then we had a study that came out sort of mid 2000s, and this had Dr. Gillison's name on it. Again, they looked at patients who are oropharynx cancer. They were HPV positive this time, and they were still managed with chemotherapy and radiation, and they had a 90+% of overall survival, which is incredible. One would argue that that's more than when you drive on the roads these days. Next slide. And ultimately, these patients they do great. And again, 90 low risk patients were 93% overall survival. Intermediate group was 70%, and these are usually the HPV, but they also smoke. And you can clearly see that in the high risk group, which is at the bottom of the screen there, these were the HPV negatives, and they were either non-smoker or smokers, but you can kind of tell that they didn't do so well. So just the fact that HPV was the causative reason, patients automatically did better, which says that this is something that responds better to therapy. Next slide. Next slide. And so let's look at what surgery did at the same time. Again, this was a paper that was published, I believe, by Dr. Holsinger, who is at Stanford, and Lecourier, who was a French surgeon. And they looked at, and this was like a part 1, part 2 paper that was published with technique and outcomes. And they looked at their patients who are HPV negative and similar outcomes with about 50 to 60% survival with surgery alone. So this was about the same as what they showed in the chemotherapy and radiation group that was done in the 1990s, where these were mostly HPV negative patients. Next slide. And then again, you see this study, and next slide again. You see this study that shows pure surgical treatment for patients now with HPV positive. Again, same type of conclusion that even with surgery alone, HPV positive disease does a lot better than HPV negative disease did. And then we go to the next slide. So then came this groundbreaking study, which I think set the precedent to what we really subscribe to right now, which is primary surgery with adjuvant therapy in the appropriate cases. And this was a study that was done by by a US based group. It's a great study that showed how patients responded to surgery and then radiation versus surgery and then chemo and radiation. And this is kind of what I use to counsel some patients where, hey, if we attempt to do surgery, you have a 33% chance that you only get surgery and your disease is done. And then there's a 33% chance that we give you surgery and radiation. And lastly, you have a 33% chance that we give you all three modalities of care. Again, this showed that HPV disease does a little better than non-HPV disease. Next slide. And next slide. So I skipped over one slide, as you guys saw, but that was a very similar European study that was done. And ultimately, there was some confusion about, okay, we do surgery, and then we do all this adjuvant therapy. And when do we do just radiation? Or when do we add chemotherapy to the radiation? And these are, again, the nuances that we discuss during our tumor board. But the high-risk features where chemotherapy showed that it was beneficial was when we see positive margins and we are unable to resect the entire tumor, or when in the neck disease, the tumor is bursting outside of the lymph node and poking its head out of the nodal capsule. So there's very defined guidelines for when chemotherapy is actually beneficial and for what patients trimodality therapy is necessary. Next slide. And then came the mid 2000s when a slew of papers came out, and they really emphasized this particular approach where, oh, we did surgery and then we did adjuvant therapy. And this is a Mayo Clinic study that Dr. Moore published. And, you can see their disease-free survival was, about 94% with this approach. And that's a really, really high cure rate. And it's something that we can deliver very, very well here at our oropharyngeal cancer program. But again, at that time, this was done at select institutions because, Mayo Clinic, they had the best surgeons then, very well-trained surgeons, and they used certain tools and that were not really available everywhere. So this is what we refer to as the pre-robot era. But people did fine, but there were select centers where they had to go to for this particular type of therapy. Next slide. This is again another paper that showed very similar outcomes and very similar approach. Instead of using electricity, they used laser surgery. And I've done laser surgery, and it's very, very hard to do. In fact, this was published by Dr. Bruce Hoey, who trained my fellowship director, Dr. Baran Sumer, who then trained me. So I'm sort of from the lineage of this particular paper. And I was trained in transoral laser microsurgery, but I was also trained in robotic surgery. And since our oropharyngeal program has been up and running here, I have done exactly 0 transoral laser procedures because they're just a little more technical to do and a little less reliable. Next slide. So we talked about how we started, with chemoradiation and how, we have data in literature that supports, primary surgery with adjuvant therapy in the right situations. And those are things that we discuss very, very candidly during our tumor board. But really what we want to highlight also during this presentation is the robot. So before I really start talking about the robot, what I want to do is just concisely summarize what we've talked about so far, because there was a lot of data, but it boils down to 4 points. That HPV-related oropharynx cancer is increasing. It is changing the face of head and neck cancer. These are well-educated people who engage in health maintenance, who are showing up with these asymptomatic neck masses. So we need to do a better job of screening those neck masses. We have to do a better job of asking patients to say, when we're seeing them in our offices. These patients tend to have a smaller primary in the mouth and a larger nodal burden in the neck. And we advocate for either primary surgery with adjuvant therapy or upfront chemoradiation as modalities of care, both of which we offer within our oropharyngeal cancer program. So then let's talk about TORS, transoral robotic surgery. This is one of the cornerstones of the oropharyngeal cancer program, and it was invented and innovated at the University of Pennsylvania as really a resident project. There was a resident who saw urologists do robotic surgery, and they were like, why can't we do this in the head and neck? And lo and behold, here we are many years later. As you know, it's one of the cornerstones of managing oropharyngeal cancer. And the reason the robot has really taken off and it's such an excellent piece of equipment is because, one, it gives us significantly improved access, excellent visualization of things that we otherwise can't see. And the main reason, I think, is that it's something that people can learn easily and it's scalable. So if you look at the next slide, when it was put into action at UPenn, all of a sudden it went all over the world. You had people from University of Alabama who came, and then Mount Sinai, and then it went international. And it's a scalable piece of technology that is intuitive to use, just like the company's name. And it's something that that makes sense. It's like playing a video game, and all of a sudden you can see and you can reach places that you couldn't before. And now it opens up that area that you couldn't reach because your hands are all of a sudden smaller. Next slide. And if you look at the trends in TORS since it started sometime in 2004, more and more procedures are being done. More people are tackling these tumors with surgery because the robot allows us to go to where we were unable to go to. And so you can see that the primary surgical approach is actually increasing for the right tumors. And I'm not saying every tumor, but for the right tumors. Whereas in the past, these were mostly, they were relegated to just one modality of care. And as we get more familiar with this technology and with the techniques that are involved in exposing and doing the surgery, our positive margin rates have been shrinking. And this is something that I've seen in my own practice, as when we started and where we are at this point in time, just how you handle the resections and how you handle the pathologists can make a very big difference in patient outcomes. Next slide. And next slide. So these are slides really for our residents and medical students. As you can see, there's lots of structures back there, which is why it's such a difficult place to work in, and it's very difficult to sort of summarize all of this right now, and it's somewhat beyond the scope of our presentation. But what we're really looking at are the palatine tonsils, the backside of the tongue, which is what we refer to as the base of the tongue. And there's a tonsil pad that sits there that some of us don't know is there. Patients, 99% of my patients tell me, oh, we had no idea we had tonsil tissue there. But there is, and that's what we refer to as the lingual tonsillar pad. And those are the sites that we're really looking at, along with the soft palate and the back of the pharynx, which is the furthest wall that you see when you open your mouth. Next slide. There's a number of muscles there, number of arteries, number of veins, number of nerves. the main arteries that we talk about are the carotid arteries. The main vein that we talk about is the internal jugular vein, and there's all your cranial nerves there. So it does require some anatomic knowledge, and how we interpret this in real time, as well as it along with radiology and intraoperative surgical anatomy. So it is a complex area, but fortunately we have the expertise and the technical skills here at the Valley to be able to navigate those challenges. Next slide. And the reason I bring this up, and sometimes to non-surgical eyes this looks very confusing, but to surgical eyes you rarely see a picture where you look at it in the textbook and you can transpose it immediately inside, in vivo, inside a patient. It's always completely different in a textbook and completely different when you're doing the operation. But this is something that shows that exact corollary, where this is what you see with the robot. And just FYI, the picture on the right is through the old robot that that was first generation. We're sort of third generation now. Next slide. With specifically with the tongue base, the challenge is also we're dealing with upside down anatomy, because you're used to looking at people face on. Your patients in the OR are inverted, so your brain sort of goes inverted. It's sort of like working when you're looking at a reflection in the mirror, and the robot makes this navigating this a lot easier, which is why it's such an instrument. It's such a great instrument to have in tackling and helping these patients out. Next slide. Next slide. And otherwise, with the robot available, the rest of the equipment is really not that special. This is all we need for, let's say, a tonsil cancer. You need a retractor and a suction, and then you have the robot that does the rest of it for you. Next slide. Little more involved with a few more retraction tools to be able to get to the back of the tongue. And we're sort of in phases to be able to accrue such a retraction system. But at this point in time, we're still able to attack both of those sites unhindered. Again, testament to what the robot can do for us. Next slide. Next slide. So what are some future directions? What are next stages in all of this? And again, I won't belabor this very much, but there's this very famous trial that's going on. It's the ECOG 3311. And really, we're trying to de-escalate their treatment after surgery. Again, the right patient, the right situation. We're trying to drop their doses after surgery for radiation, in the hopes of getting the patient a better outcome. So there's significant work that's happening in trying to de-intensify their care. Next slide. Here's another one that's going to come out soon. And this is the AVOID trial. I think it's very aptly named because they're talking about trying to omit radiating the back of the throat once you've taken the tumor out, and if you've taken it out well, and only treat sort of the neck bed, which again limits the amount of post-operative treatment in the form of radiation that they need. Again, all in the hopes of getting patients a better outcome. And we have to do this very conscientiously, understanding that we don't want to put people at risk of recurrences, but we go where the data goes. Next slide. And so this is the new robot, and I put it in this presentation as something that is a future project, but it's actually a present project for us. And if you look at the third picture, the one sort of mid-frame at the bottom, you kind of see that we open the patient's mouth, the robot goes in there, and we're able to take these primary tumors out without really making any facial incisions. That's because the robot sort of goes inside the mouth and it grabs open, and then you're able to work. You're working back there, and it's a massive contrast from what we used to do, as you saw in the earlier pictures, compared to what we're able to do right now. And it's very heartwarming to say that we're able to do this right here at the Valley, and we're approaching about 50 cases now in less than a year. So next slide. So I think, having gone through those slides, Lori, I went 30 seconds over. I told you 28:30, but it's 29. But that sort of wraps up my portion of the presentation. We're able to do these things here. Watch out for your patients. Ask them to open their mouths, look at their tonsils. If they have a neck mass, keep HPV related head and neck cancers in mind, for ourselves also, and for our patients. It's something that's a public health crisis. It's a public health epidemic, and we're proud to say that we can take care of these patients here locally. So thank you for your attention.
Thank you, Dr. Alwani. We appreciate that. So I would like to remind everyone, before I introduce Dr. Kadakia, to put your questions in the Q&A at the bottom of your screen. I know we're starting to get some things populated. So I'd like to introduce Dr. Sameep Kadakia. If you go to the next screen, please. Dr. Kadakia is the director of our Premier Health Comprehensive Head and Neck Cancer Program. He started the program, in 2019, I believe, Dr. Kadakia. A lot of passion and a lot of compassion for his patients, and hard work to pull that together. He is double board certified in head and neck surgery and facial plastic and microvascular reconstructive surgery, including fellow training at Baylor Medical Center in Texas. His subspecialty interest in complex head and neck surgical oncology included open skull-based surgery, medical degree at Drexel, University of Philadelphia, residency in head and neck surgery at Mount Sinai Health System in New York City, performs oncologic and reconstructive surgery, including endocrine surgery, maxillofacial trauma, Mohs reconstruction, ablative oncology, microvascular and regional reconstruction, and management of post-radiation wounds and recurrent malignancy. Dr. Kadakia is also the associate professor at Wright State University, Boonshoff School of Medicine and General Surgery and Plastic Surgery, and an instructor in the ENT program. He also completed a fellowship at Baylor Medical Center in Texas in facial, plastic, and reconstructive surgery with a special focus in advanced head and neck oncology and reconstruction. And wow, that was impressive. So Dr. Kadakia, I'd like to kick it off to you. And again, put your questions in the Q&A. That would be great. Thank you.
Thank you so much for that warm introduction, Lori. And Dr. Alwani, that was a phenomenal presentation. So thank you so much for sharing that with us, and also for bringing the robot technology and adding an incredible dimension to this program. Over the next 30 minutes or so, I'd like to switch gears a little bit. And the first half an hour of this webinar, we discussed advances in oncologic surgery. The next half an hour, I'll change gears and talk about advances in reconstructive surgery. And both parts are equally important in our cancer program. And now that we are able to offer patients better reconstructive modalities, it's also been able to push the ability to perform oncologic surgery a little bit more in depth as well than what we previously used to be able to do. Next slide, please. So over the next 30 minutes, I'd like to explore the evolution of head and neck reconstruction with you, so we can better understand together how challenging the functional rehabilitation of these patients can be, and the unique applications of modern day technology, so we can precisely and efficiently guide our reconstructive management. Next slide, please. Next slide. So first, I want to take a little walk down memory lane. Over the last 100 years or so, we've noted a number of paradigm shifts in the management of head and neck cancers. Initially, patients were treated preferentially with surgery, but oftentimes the surgeries were quite radical and the quality of life was significantly impacted. And this was largely due to the paucity of reconstructive techniques and a better understanding of more targeted therapies, which we now offer as commonplace in 2024. So previously, when surgery was really the only modality that was championed, at one point the pendulum then swung, and at that time surgery was largely deferred in favor of radiotherapy. But that also was not without risk. We began noticing soon after that, and also much more so now, the late effects of radiation, which have also been quite challenging to ameliorate. And I think now, especially, we've been able to notice what the late effects of radiation are, even for patients that may have had radiation 10, 20, 30 years ago. In current day, we've actually struck a very delicate balance between the indications for surgery and non-surgical approaches, all the while maintaining a patient-centric, tumor site-driven approach. Similar to what Dr. Alwani was saying, rather than saying that all patients should get surgery or all patients should get chemoradiation, now with the advent of our multidisciplinary tumor board methodology, every patient gets a customized plan where we can say, okay, well, some patients may need radiation alone, maybe some patients need surgery alone, maybe some patients need surgery with the plan for postoperative radiation or chemoradiotherapy. So the nice thing is that we've taken a much more individualized, customized approach to cancer care, which previously was not as customized. Next slide, please. So when we think of the era of when complex oncologic surgery began, we pay our respects to these three individuals, Dr. Jodinsky, Kreil, and Hayes Martin. And what's interesting is that these three gentlemen were all big pioneers in general surgery, and they were the ones who actually pioneered the initial head and neck oncologic procedures. And although initially all of these procedures were quite radical, and oftentimes they were quite compromising of functionality, the oncologic basis of what we do now has been refined over the years through these initial discoveries. Next slide, please. So as surgical management became more and more common and also resulted in more morbidity, the need for reparative surgery arose, reconstructive surgery. And initially, we began with techniques where only local tissue was used, and then we transitioned to pedicled flaps, and then later we progressed to free tissue techniques. And briefly, just to give an overview of what these different terms mean, local tissue is similar to saying, listen, you have a wound in someone's face. Is there a way that we can move some face skin over to repair that wound? That would be an example of a local flap. When we move on to what's called a pedicled or an axial flap, it basically implies that the wound that is present, it can't be repaired by something that is so available locally. So we go one step a little bit farther and we look at some tissue that may be nearby, but a bit away from where the wound is. And when we move this tissue over, it remains attached to its feeding blood vessel. And that's what we call a pedicled or an axial flap. And then, of course, the most complex and nowadays the gold standard for many oncologic procedures and for many trauma-based procedures is what's called the free tissue microvascular reconstruction, also known as the free flap surgery. And this basically functions as a mini transplant where skin, muscle, bone, or some combination of all of them is transported from one distant body site to another site in an effort to rebuild that which was resected. Over the last several years, we've experienced an even newer technology now that has further optimized our ability to reconstruct, and especially in regards to bony reconstruction, which we call oromandibular reconstruction, reconstruction of the oral cavity and the mandible, oftentimes jointly performed. So with this new technology, we've been able to specifically improve our outcomes with regards to oromandibular reconstruction because the ability to apply computer-assisted technology has allowed us to pre-plan a lot of the reconstructive surgery before we even get into the operating room. So I'll go over this in a little bit more detail in a few more minutes, and this really will be the highlight of this conversation. But in broad strokes, when we have this form of planning, surgeons like myself and Dr. Alwani, if we have a patient that has a mandibular tumor, prior to surgery, after their CT scans are completed, we can meet with an engineer online. We can together study the patient's tumor, look at the patient's CT scan together, jointly discuss where the mandibular cuts or what we call osteotomies should go. And then with that, we can also have the engineers design a customized plate that is three-dimensionally printed. And along with that, going one step further, we can plan the reconstruction. So if a patient is having a mandibulectomy, meaning resection of a mandible tumor. And we say, listen, for this particular patient, we think that the fibula free flap is going to give us the bone and the skin that we need to resurface the bony defect as well as the oral cavity defect. Using the same patient's CT scans of the leg, those same engineers can say, you know what, when we look at this mandibular defect, say it's 5 centimeters, we can plan on taking 5 centimeters of the right fibula. And again, based on their cuts, they can precisely give us plates and cutting guides that then allow us to quickly and efficiently perform that part of the operation. So with the deliverables that they give us, which usually include some kind of a plate, some kind of a cutting guide, oftentimes even models that can guide us, we're able to precisely design and have a very carefully thought out plan even before the day of surgery. So this is something that, again, when I was in residency, we hadn't been doing this. In fellowship, we started transitioning. This process could easily take an hour, hour and a half in the operating room, which now, because of all the pre-planning, we can save that hour, hour and a half of anesthesia time and allow the patient to get out of surgery a little bit quicker. So like I said, that'll be the focus of my portion of the talk today, and we will revisit this a little bit shortly. Can we go to the next slide, please? So now going back to the evolution of head and neck reconstruction, through that ladder that we talked about where we went from local tissue to pedicle tissue to free tissue, now we've been able to make significant advances in our field. So when you look at this photo over here, this photo is basically a picture of a patient that was treated during the World War time by Dr. Harold Gillies, who's known as to be one of the fathers of reconstructive surgery. And again, patients who had nasal defects were sometimes treated with flaps from the forearm, which, as you can imagine, while it may get the job done, it's quite cumbersome for patients. Can we go to the next slide, please? So compared to that, now we have techniques where, and this is a patient who had an invasive fungal infection of his cheek. He was a diabetic renal transplant patient. One of my patients who, during my fellowship year, we had taken for debridement. And if you look at the face, what you are seeing is the teeth through the cheek because the fungal infection had not only eaten all that tissue, but we had to debride all of that to clean it. Can we go to the next slide? So compared to the slide that we saw 2 slides ago, now with free tissue techniques, we can harvest what we call radial forearm free flap, meaning we can take skin from a patient's forearm, transplant that into the face. And when you look at the photo on the right side, this is the patient several weeks after his initial operation. So he looks relatively more normal than he did before. Again, once the sutures all are, once they dissolve and that skin further incorporates, the color match is quite good, and the patient will be able to have a nice functional recovery. Next slide, please. So now we're going to transition more to speaking specifically about what the advantages are of free tissue reconstruction, and namely of the custom planning that I was talking about. This is a stock photo of a patient online who has a mandible tumor. And you can see that on the left side of the screen, the patient's right side of his mouth. Can we go to the next slide, please? So again, this is a stock CT scan, not that particular patient's CT scan, but one that I found for illustrative purposes. This CAT scan basically shows what a mandible tumor may look like. Next slide, please. So if this patient was going to have surgery, he would need what's called a mandibulectomy. And as I mentioned before, a mandibulectomy implies some portion of bony resection to remove a tumor. Now, we have several different kinds of mandibulectomies. If you look on the left side, the marginal mandibulectomy is basically what we call a rim mandibulectomy, where a tumor may be abutting the mandible without actually invading the mandible. So to not only allow visualization and clearing the margin, but also for ease of exposure, we can perform a rim mandibulectomy where a small amount of mandible and teeth may be resected. And again, you still maintain the majority of the jaw structure. Most of our sources say that as long as you leave about 11 millimeters or more bone, the patient can retain relatively good jaw structure, again, barring that they are not edentulous patients or that they are not previously radiated. When you look on the right side, in contrast, a segmental mandibulectomy is essentially a full thickness resection of the bone, which we have to do if the malignancy is invading the cortical bone, meaning the outside of the mandible. Can we go to the next slide, please? So previously, when patients had to have mandibulectomy, they oftentimes had this deformity that this poor gentleman has here. And when you look at this gentleman, he's clearly had mandible surgery, but there's no support to his jaw. And as a result, his whole jaw has retruded and the patient is tracheostomy dependent. the mandible is very, very important for airway stabilization also. And without the appropriate reconstructive techniques, which weren't present many, many years ago, again, they've gone through multiple iterations, and we'll speak about sort of the most latest and greatest in a few minutes. Patients had this deformity, which, if you go to the next slide, please, was at one point called the Andy Gump deformity. And this was actually a cartoonized version of this deformity because patients with mandible cancers were having these procedures done. And unfortunately, in sort of a derisive way, some of the media had painted pictures like this, sort of illustrating that patients essentially looked like they had a top lip and a mustache, but really no jaw because the whole tissue was retruded. So for these poor patients, again, airway issues were common, tracheostomies were common, feeding tubes were common, oral communication was almost null. So that is where we came from. So let's fast forward to where we are right now and where we will continue going over the next years. Can I have the next slide, please? So really now the crux and the gold standard for oromandibular reconstruction is microvascular free tissue transfer, which I mentioned is the free flap surgery. And again, this has been further augmented with our 3D custom plating and patient-specific planning software that we had discussed previously as well. Next slide, please. So for the next several examples, we're going to use the fibula free flap as an example because for mandibular reconstruction, the fibula free flap does remain one of the workhorse flaps. So if you look at this picture, this is a schematic of a patient's lower extremity. The fibula free flap itself is not a weight-bearing bone, and that's why it can very readily be used, again, barring that the patient has appropriate vasculature for mandibular reconstruction. This bone can be harvested with a piece of skin along with some muscle as well. And the key things are that the superior part of the fibula, part near the knee, we preserve about 6 to 7 centimeters of that. The fibula does not participate in the knee joint, but one of the main nerves, the peroneal nerve, does wrap around the head of the fibula. So we preserve that area. And then inferiorly at the ankle, we preserve another 6 to 7 centimeters because while the fibula bone is not weight-bearing, that inferior part does help stabilize the ankle mortise. Can we go to the next slide, please? So again, this is also a stock photo to illustrate just how far we've come with fibula free flap alone and with custom planning. When you look at this patient on the left side, this young woman has a mandibular tumor. So if you look at the CT scan directly below, you can see a mandibular tumor growing out of the right side of her jaw. Then following reconstructive techniques and extirpative surgery, the patient's face looks relatively normal. She has good contour, good symmetry. And if you look at the CT scan below, what you can see is that there is a 2-segment fibula, meaning that the fibula bone has been cut into 2 segments, and using that segmental osteotomy, the surgeons have been able to recreate a relatively normal occlusion and contour of her mandible. And this also has been facilitated with plates, except in this particular patient's case, we don't see a traditional heavy mandible plate like we use nowadays. But again, the point being that the fibula free flap has changed the way that mandible reconstruction is done, which then in turn has allowed us to perform more mandible extirpative surgery. Next slide, please. So now to go over some more details about what the custom planning process entails. When you look at this image, this is basically the start of several images that we see when we perform the preoperative planning with the engineers. So when a patient comes in, this particular patient has what's called a pathologic mandible fracture, meaning that they had radiation for a head and neck cancer. And unfortunately, due to the radiation osteitis and radiation arteritis, the mandible developed a fracture, as in the mandible was not able to sustain itself. There may have been an inciting event, some trauma, some infection, but ultimately the mandible cracked. So what you're seeing is that the mandible has been displaced as a result of that fracture. So when you meet with these engineers first, the first thing that we see is this preoperative photo. And the CT scan shows where this cut is. And again, the dark gray segment is highlighting the ramus and the portion that likely will not be changed as much. Can we go to the next slide? Then in the next slide, what we're seeing is that the mandible has now been repositioned. So what they can also do is using the normal anatomy, which in this patient's case was on the left side, they can move the segments through their software to give us an idea of if this was a mirror image of the left side, where would the mandible likely sit? So the green is basically the projected repositioning. Next slide, please. So now what this shows is what the postoperative anatomy is. So basically using that repositioned green segment, if we had planned together and said, okay, well, the part of the bone where the fracture was, if we resect that bone and if we reconstruct it with a fibula flap, this is what we ought to try to give the patient. So this is a simulated postoperative anatomy CT scan. Next slide, please. So with that, the engineers can then tell us, okay, well, if we say we need to resect about 6 centimeters of bone and replace it with about 6 centimeters of bone from the fibula, in order to allow that bone to fit in a way that maintains the geometry of the mandible that is favorable for occlusion and for chewing, this is a projected plate that needs to be put on there. So again, with dialogue between the surgeon and the engineer, we can design a customized plate. We can design everything about this plate in terms of how thick it is, how many holes it has, whether we want it to be in this configuration or a different configuration, how many bends it needs to have. So this is an example of a plate that can be designed. And again, this plate, once we all agree upon it, will be fabricated to match this exactly. And this is the plate that will show up on the day of surgery. Next slide, please. So with the plate, they also give us what is called cutting and drilling guides. So basically, if you look at the overlay guides on the screen plate, those are the guides that can be fixated onto the mandible at the time of surgery. And then those guides can basically allow us to know where to make our cuts based on our preoperative planning, and also where the screws will go to further facilitate putting this plate on quickly and efficiently. Next slide, please. And to take it one step even further, using the CT scan, the engineers can also give us an idea of what size the screws are. So depending on the thickness of the mandible, the engineers can also say, okay, well, this screw needs to be about 6 millimeters. This screw needs to be about 8 millimeters. So again, that also has taken a lot of the guesswork and a lot of the thinking out of this part of the surgery, which we can now rely on a more data-driven, patient-specific approach. Next slide, please. So now what I'll do is I'll give 2 illustrative examples of how this technology is used, really to paint the picture of how much it has contributed to our ability to better reconstruct our patients now. So in this particular vignette, this is a patient who had a history of oropharyngeal squamous cell carcinoma, previously had chemoradiation many, many years ago. When I particularly saw this patient, I believe he had been radiated about 20 years ago. And unfortunately, the gentleman began having jaw pain, came in with the typical story that he was eating, I think it was a chip or an apple. It's usually something crunchy. And when that happened, the poor gentleman began to notice significant pain and a crack sensation in his jaw. So when he went on to have testing done, he was found to have what's called a pathologic fracture as a result of this radiation necrosis of the mandible. Next slide, please. So this is a picture of the patient's oral cavity in the operating room, and it's a little bit difficult to see, but on the right side, you can start to see a bit of a step off between where the teeth end and then the posterior part of that mandible. Next slide, please. So with this patient, we performed the patient-specific planning. So prior to surgery, we looked at his CT scan. And if you look at this preoperative CT scan, what this is showing is that the mandible has fractured right at the body. So basically just in front of the angle of the right mandible and just behind the parasymphysis, meaning the part of the mandible that is directly lateral to the chin, there is a fracture going through the body of the mandible. And that's the fracture that relates to the trauma that the patient felt when he was eating that crunchy item. And as an aside, that's unfortunately not an uncommon story with a lot of these folks who come in with pathologic fractures. And oftentimes when they have this characteristic story, we do have to suspect that they have undergone a pathologic fracture. Can we go to the next slide, please? So then moving on to the preoperative planning. So now that we examine what that preoperative scan looked like, then we say, okay, well, if we were to resect all the bone that was unhealthy and place a fibula free flap, this is what it would look like. So this is the simulated free flap that is now situated in this patient's mandible. Next slide. So now I'll show you some intraoperative photos of the same patient. So when you look at this patient, so now, previously we had seen that fracture in the oral cavity. Now an incision has been made in the right neck, the skin has been elevated, and now you're able to directly look at that fracture. So compared to that CT scan that we saw several slides ago, you can see a clear fracture between 2 parts of his jawbone over here. And that is really just between the two fingers on the glove that you're seeing. Next slide, please. And in this photo, the instrument is right between that fracture. So now let's go back to our planning session. Next slide, please. Where in the planning session, before we had, we had designed what the projected mandible should look like after reconstruction. So now in order to get there, we talk to the engineers and say, okay, well, in order to have that, where do we need to make our bony cuts? So using these customized drilling and cutting guides, we are able to say, okay, well, one of our cuts is going to go just a centimeter or two superior to that fracture, and then the other one will go just a centimeter or two anterior. Next slide, please. So now looking at this picture, this is a picture of the cutting guide for the fibula. So now that we've said, okay, well, we know what the cutting guides are going to look like, we know what bone is going to come out, now let's design the appropriate reconstruction. So using the patient's CT scans, this is a cutting guide, also called the jig, where we can measure that up to the patient's own fibula, again, all based on CT scan planning, and say that the exact shape that we will remove at the time of surgery, let's plan that the exact shape will be harvested from the fibula at the same time as surgery. So basically that piece should fit into his mandible like a jigsaw puzzle. Next slide. So again, in this photo, what you're seeing is that mandible with the fracture, now we are making the cuts. So what you're seeing here is there are several instruments at the left of the screen that are retracting the skin, and then you're seeing a saw that is getting ready to perform the first mandibulectomy cut. Next slide, please. And over here, what I've done is I have superimposed that fibula free flap. So again, going back to the fact that we have these custom cutting guides, and you can't see the guides very well in this photo, but basically the angles that I'm making the cut in, if you look at the saw that's being held by the hand, that angle should almost nearly match the same angle as the fibula bone graft that's going to be put in there. So point I'm trying to make is that when you look at the fibula bone graft that we've designed, that should fit like a key into the resected ends of the mandible, as long as we follow the same cutting guides throughout the procedure. Next slide, please. So again, next slide. So now going back to the preoperative planning, when we had talked with the engineers about what side of fibula we wanted to put in, what size, then we had said, okay, well, in order to accommodate that size of fibula bone, this is the type of customized plate that we need. So we had said that we would like 3 screw holes anteriorly, 3 screw holes superiorly, and 2 screw holes to fixate the actual fibula graft. So then the engineers, they're able to prepare this kind of a plate, and on the day of surgery, that exact plate shows up in the operating room along with all the cutting guides, which I showed you before. Next slide, please. And then along with that, like I mentioned before, you can also have an idea of what size the exact screws need to be as well. Next slide. So now going back to our intraoperative photo, now that that piece of mandible has been resected, this exact plate that we designed based on the CT scan has now been applied to fixate the mandible in the geometry that we want to fixate it in. And again, I'll draw your attention to the defect of the bone over here, and just keep that picture in mind along with the picture of the fibula that we had designed. Next slide, please. And again, over here, I have superimposed that same fibula graft into where it's going to go and fit in like a puzzle. Next slide, please. So going back to the preoperative planning again, that fibula flap was planned on the CT scan. Again, looking at the patient's tibia on the left side and the fibula on the right side, you can tell that all of these designs are done very, very accurately, and you can design how far from the ankle you want to harvest the graft. You can design exactly how many millimeters it's going to be. You can design exactly what the degrees of the cuts are going to be. So this is all completely customized based on what the patient needs and what the discussion is between the surgeon and the engineer. Next slide, please. So this is an intraoperative photograph of the patient's leg, and this is the fibula free flap that is being harvested. So if you look at the fibula free flap here, in the gloved hands, the surgeon is holding the skin paddle, and just above that, you can see the strut of bone that has now been removed from the patient's body. Next slide. And here's another photograph of that. Next slide. Another photograph of the fibula template that we'd like to use. Next slide. So that fibula template now is fixated to the fibula bone in the patient's leg in preparation to harvest that same bone graft. So just to backtrack, we have now prepared the fibula free flap, and we will now customize that fibula free flap to meet the patient's exact needs. Next slide, please. So once the cuts are made, this is a picture of the fibula free flap on the back table, where we are performing further contouring with several instruments that we have. And once we have the amount of bone that we need, the remainder of it can be kept aside in the event that additional bone is needed. Next slide. And again, just to match how exact the cuts are, this template near perfectly matches the exact amount of bone that we want. And it's all the same cutting guides like we mentioned before. Next slide. So now this fibula free flap, and this is not the best picture, but the intraoperative photograph of the fibula free flap from the leg is now superimposed. And what I've done is I've kept those same angle markers to show you that the cuts are so exact that they should fit in perfectly. Next slide. So that bone has now gone in there. And what you're seeing now is that after the bone is screwed into the actual plate, the skin of the fibula has now been used to recreate the inside of the oral cavity. So if you look at the picture, what you're seeing is, again, just inferior to that silver instrument is a oval patch of kind of whitish pinkish tissue, and that is the skin that came from the patient's fibula. So that lower extremity has now donated essentially a piece of skin and bone that we've been able to use to rehabilitate the mandible, as well as the opening in the oral cavity that we had to make to remove that mandible. Next slide. And this is a picture of the neck after it's been sutured closed. Next slide. Next slide. So now I'll illustrate one final case. And again, this sort of ties everything together, and it gives us an idea of, again, where we were and what all we were able to achieve. And I really like this case as a final case of our presentation, because when you see the patient's outcome, it starts giving you an idea that nowadays, again, cancer treatment is challenging, surgery is challenging. But with, I think, how algorithmic things have become, how data-driven things have become, with the right patient and the right approach that's multidisciplinary, patients do very well. And sometimes when we are performing these treatments and we're putting them through it, it's difficult to know what it looks like when everything's completed. But again, with the right support, patients do quite well from it. And then it gives further credence to the multidisciplinary approach that we take for our patients here. So with that, the last case is a gentleman who had a history of an advanced oral cavity squamous cell carcinoma that was involving the majority of the right half of his mandible. Next slide, please. So this patient was taken to the operating room, and what you're seeing over here is following mandibulectomy, this patient's right hemimandible is here on the back table. So basically at the top of the screen, you're seeing the part of the mandible that articulates with the temporal bone, and then just below it, that whole mandible has been eaten away by tumor. Next slide. In this picture, again, slightly different plate than the ones we had showed you before, but still a customized plate. This plate is supposed to match what was removed from the patient's mandible after the cancer surgery. Next slide. In this image, what you see is that the neck has been retracted. So if you look at the left of the screen, you're going to see the carotid artery, the jugular vein, and the spinal accessory nerve. Just anterior to it, you're going to see the hypoglossal nerve. And then above that, you'll be able to see the actual titanium reconstruction plate that I showed you in the picture before. But again, that plate is customized for this patient's anatomy, so all the curvatures should match. And that plate, if it sits as the way that we want it to, should help the patient get back to eating regularly as well. Next slide. So this is a picture of a fibula free flap. Again, it's been custom cut. I didn't go through all the same images to show the cuts, but this is a small segment of fibula, which we took with some blood vessels and muscle. Next slide. And over here, that fibula free flap has now been implanted within the plate. So if you look behind that empty plate, which we had a few slides ago, now that bone has been inset into that plate with several screws. Next slide, please. And over here on the left side, what you'll notice is that some of those blood vessels that we pointed out before have now been hooked up to the blood vessels of the fibula. And in the leg, the fibula is supplied by the peroneal vessels. What happens is that when you transplant it into the head and neck region, you have to give it a new donor artery and a recipient vein, because every free flap is like a small circuit where blood has to go into the graft in order to perfuse it. and a vein has to return the blood out so that way the tissue does not become congested. In this particular patient's case, the artery was hooked up to a branch of the facial artery, which you can't see very well over here, but the external jugular vein was used as one of the recipients for the venous anastomosis, meaning that is where the peroneal vein was hooked up to the external jugular vein. So now this circuit is complete, so to speak, on the table. Next slide, please. And this is the patient's neck after it's been sutured closed. And this patient went on to do quite well. He received postoperative radiation. He recovered well. He had his tracheostomy removed several months after the completion of his treatment. He got back to complete oral intake, and he also had his feeding tube removed. So with that, I will show you the last photo of the patient who is several months at the completion of his rehabilitation. Next slide, please. So as you can tell, the gentleman has an excellent contour of his mandible. With the way that his beard has grown, it actually has completely camouflaged the incision as well. And he looks relatively similar to how he did before he underwent all the treatment. So with that, I'll conclude by saying that there has been a tremendous amount of advance in both oncologic and reconstructive surgery. And it's been really amazing sharing with you, again, over the first half an hour, the application of the robot to advancing oropharyngeal oncologic surgery. And then the second half of the presentation showing how, again, the use of technology has been able to revolutionize how we reconstruct patients. So again, with both of these working hand in hand, and of course, collaborating with our radiation colleagues, our oncology colleagues, and the other members of our tumor board, we're able to offer patients a significantly better experience and a more comprehensive way of cancer management nowadays than we were many, many years ago. And as a result, our patients are doing better, and we have a greater focus on the quality of life as well. So with that, thank you so much for your time and attention, everybody. I will pass it back to Amanda for the Q&A session.
Thank you, Dr. Kadakia. So we do have a few questions in the chat. And the first one, Dr. Alwani, we're going to have this question go to you. How or what makes transoral laser surgery less reliable?
That's a great question. Is this coming from a practicing ENT, or is this coming from do we know who it's coming from, just so that I can tackle it and give it its due respect?
I can see the last name of Reynolds.
Okay.
An RN.
Okay. Honestly, it's an excellent question, and so we can talk about it from an evidence-based standpoint, and we can talk about it from an anecdotal standpoint. From an evidence standpoint, there's studies that have shown that transoral robotic surgery and laser surgery give you equivalent oncologic outcomes when it comes to larynx cancers. There's one study, very small sample size, that showed the two compared side by side with regards to oropharynx cancers, which is what we talked about today. And despite the fact that both had similar oncologic outcomes, there were differences in the operative time as well as the rates of feeding tube placements over the long term, where the laser surgery group had more of that and the robot group had less of that. And we can go into the weeds and argue both sides with evidence and data, but anecdotally, this is what I'm going to say. So transoral laser microsurgery was really pioneered by a German physician whose name was Wolfgang Steiner. And if you look at Steiner's case series, he has done about, let's assume he did 100 cases, all of the 100 had their cancers cured. And so in Dr. Steiner's hands, laser surgery is a miracle cure. But we're talking about the general population. We're not talking about the star athletes of head and neck cancer surgeons. We're talking about the mere mortals. So we're talking about the Alwanis, not the Kadakias. And for the mere mortals, you need a technology that is easily usable and that you can teach and replicate. When you are working with the laser, you're working through a small opening, very small opening that you sort of have to move around in a very specific way, keeping track of your entire environment, sometimes parts that you can't see and sometimes parts that you can see. And in the right hands, if the technical skills are there, it gives you the same results, but it's technically more challenging than using a robot where you have $1 million screen that can show you the entire field all at once, and you're moving your hands just the way you would be moving them, rather than moving a small dot stabilizing your hand. So the differences in reliability come from the technical demands of those two technologies. And as someone who does both, I certainly found that using the robot is more intuitive. There's better visualization. It's easier to use, so your operative times are less, and it just gives you better access. So in that sense, it is I think it's a little more superior than laser surgery, which is why trends are such that there's more robot being done than laser. But they're both excellent, tried and tested ways of doing things. And again, it really depends, it depends who is doing the surgery and whether they're doing it appropriately from the technical standpoint.
Thank you, Dr. Alwani. The next question is for Dr. Kadakia. And what is the value of offering microvascular reconstruction to the oncology patient population?
Thanks for that question. That's a really great question, because I think it does speak to the ability to reconstruct, like I was saying before, allows us to do more from a cancer surgery point of view. And I think, kind of like I touched on earlier in the presentation, that nowadays it's not so much just the ability of removing cancer, right? I think many times patients come in, and I think formerly the thought process was that, oh, it's cancer, it's bad. Once the cancer is removed, that's really the end all and be all. But I think we've progressed pretty significantly from that era, where we've realized that, you know what, we've gotten pretty good at removing cancers. We've gotten pretty good at treating cancers. But I think the onus now is on the reconstruction part of things. And the onus now is on the rehabilitation part of things. Because it's great that a patient doesn't have cancer, but what do you do with the quality of life after the cancer is removed? Again, there are some situations where you have to make decisions and you have to have a goal-based discussion with the patient. And you say, listen, after this type of surgery, maybe, unfortunately, maybe your speech will not be very good. Maybe you will not return to eating by mouth. Maybe you will not do X, Y, and Z. But if your main objective is to do this, we might be able to do this for you. So depending on the situation, I think we can have a very tailored conversation about what the patient's goals are and what, as providers, we can reasonably accomplish for them. Where microvascular reconstruction comes in is that it allows us, I think that surgically allows us to be limitless in a way. And by limitless, I'm not saying that we operate on patients that are poor candidates. I'm not saying that we operate on patients that have tumors that are not resectable. What I'm trying to say, though, is that in a patient where you would ordinarily say, you know what, if I remove this much of a patient's tongue and the swallowing is going to be a problem, or the speech is going to be a problem, or say they're going to have a lot of scarring after surgery. Compared to that, in nowadays, if we have the ability to say, okay, well, you know what, we know that based on our tumor board discussion, we know based on the patient's preferences, we know based on what the data is telling us that surgery is the best thing to offer a patient initially for a tongue cancer. But instead of letting them suffer through the quality of life compromise that they may have, many, many years ago, instead we can say, you know what, we can use a graft of skin from your forearm. We can use a free tissue graft from your thigh or your back. Any of these things to basically restore the part of the tongue that we've taken. So now, while we've removed that dysfunctional part of the organ that was affected by cancer, we've also been able to replace and almost patch up whatever trauma we created as surgeons to do our best job at getting that patient going forward. And what we found is that with the example from tongue surgery, that with the ability to replace that which we have removed, you can get patients better swallowing outcomes. You can get patients to get better speech outcomes. You can get patients to have less scarring and things like that too. So I think it's allowed us to be a lot more mindful, but also it's allowed us to not shy away from situations because of quality of life issues altogether.
Thank you for that. I do have a couple more questions that came in, and this one's for Dr. Alwani. What are preventative efforts around HPV-related oropharyngeal?
Yeah, great question. I think prevention, as far as oropharyngeal cancer goes, has everything to do with vaccination, early vaccination, and Gardasil, which is something that has been used for cervical cancer, covers 4 strains. Covers 16, 18, 31, 33, and those are the malignant subtypes that we talked about. It also happens to cover the same subtypes are the ones that cause HPV-related oropharyngeal cancer. So it's a very simple answer: vaccination, and that ought to be done early in life, at the age of around 10, 11, 12, 13, and that's sort of what public health guidelines recommend right now. So a very straightforward answer is get vaccinated. And if you aren't vaccinated as a child, there's some value in getting vaccinated even as an adult, especially before the age of 40. So prevention, vaccination, they're synonymous.
Thank you, Dr. Alwani. I have another question for Dr. Kadakia. How often do the fibula flaps fail? And with all of the pre-planning that is done, are you able to use the other leg and try again?
Great question. So the all in all, so free flaps are very successful nowadays. And depending on what data you look at least in the United States, the success rates of free tissue reconstruction, again, fibulas are part of this, and all the data sort of lumps all of them together. So whether it's fibula flaps, radial forearm flaps, latissimus flaps, et cetera, the overarching statistic they give is it's upwards of 95%. In some centers, they may even say 97%. I don't know what the worldwide statistics are because I think a lot of it depends on reporting and a lot of it depends on how much it is. But at least in the United States, if you're banking on a 95% success rate, that's pretty high. And if you were to say, okay, well, say we have a sicker population, maybe you say 92, 93%. Even at that rate, that's a very high success rate. So within that, fibula flaps being a sort of a subset of those free tissue reconstructions, again, we can assume that the success rates are well above 90%. And then similar to the, I think the second part of the question was, can you repeat the second part? I think it was about using the other leg. I don't see the question any longer.
Yep, it was about using the other leg and trying again.
Got it. Okay, great question. So yeah, if say for instance a fibula flap is done and it dies or doesn't do well, you certainly can use the other leg. What we always do is before a patient has a fibula free flap, we always get a CT angiogram. In some institutions, they may get a formal angiogram. Some institutions, they do what's called an MR angiogram, sort of like an MRI, but for the leg. And the main purpose is to see, okay, well, if we're going to be harvesting the fibula, the fibula comes with a blood vessel, the peroneal artery, which can be something that continues on to perfuse the lower extremity. So typically in the lower extremity, you have your anterior tibial vessels, your posterior tibial vessels, your peroneal vessels. In most patients that are healthy, you have what's called 3-vessel runoff disease, or sorry, 3-vessel runoff. So what that means is that even if you harvest the fibula, despite taking that blood vessel, there's enough additional blood vessel that's going to the leg that the patient's leg will not be compromised in any way. So we always check that. And again, in a patient who has peripheral vascular disease, or if there's any concern regarding perfusion of the foot after harvesting this, then we won't use that as an option. We'll say, okay, well, where else can we get bone from? Will we get bone from the radius bone? Will we get bone from the scapula bone, etc.? But if you have a patient where the CT angiogram shows that both of the lower extremities are great, and the patient hasn't had any significant morbidity or functional compromise on the side that's already been used, by all means, no reason to not attempt with the other side, so long as the patient is willing to and the overall bill of health will support it as well. On the other hand, if the CT angiogram is done and it shows that, hey, the contralateral leg has, only one vessel runoff, for example, or say the patient had some kind of a complication where their ambulation was affected. In that patient, you probably would hesitate towards using that same leg. But in contrast, you may say, okay, well, if we need to give it another shot, what would it look like to try harvesting a piece of radius bone or try using a piece of scapula bone? So the fibula, again, is probably the best option for most mandibular reconstruction, but it is not the only option. And that's why every free flap surgeon usually has a number of bony and soft tissue reconstructive options under their belt for this very reason.
Thank you, Dr. Kadakia. I do not see any more questions coming in at this time, but we wanted to thank everyone as well, and then offer everybody their email addresses and phone numbers. So I don't know if anybody wants to wrap it up about the thank you.
Dr. Kadakia, any last words?
No, I think this was really excellent. Really great to have this conversation and share something that we're so passionate about and something that we've really been working hard to build further in Dayton. And without the support of all of our collaborators and all the providers in the community, all of our staff members that we work with, none of this would be possible. So again, thank you everyone for taking time on a Wednesday evening to spend with us, and we look forward to continue building with you all.
Dr. Kadakia, do you have time for one more question that just came in?
Yes, I do.
Okay.
Yep, no problem.
So you said patients may never go back to eating normally. What is the recommendation for soft diet post-surgery? Is there a recommendation to eat on collateral side, or is there a jaw wired shut post-surgery? And if so, how long? So if I need to repeat any of that, let me know.
Sure. You know what? Let me see. Is it in the
It's in the chat. Yep.
Let me just double check. Okay, good question. So you know what? So that's a great question. So what I was referring to in terms of patients not being able to eat normally, what I was referring to is not so much with these particular procedures, but for some patients that may have very aggressive tumors or require very sizable resections, or say patients who have already had a lot of functional compromise, that's sort of a unique subset. I think if we focus on the patients, again, from this conversation, whether they've had robotic surgery or fibular free flap reconstruction, generally the goal is for them to go back to eating normally. If we look at just diet after surgery, so focusing on the free flaps, because again, patients who have had free flaps, their oral rehabilitation is a little bit different than patients who have not had free flaps. But again, for the free flap population, usually what we do is for the first week, we will keep them NPO, meaning that we'll either use a nasal feeding tube or a abdominal feeding tube, so that way patients can get the nutrition they need to rehabilitate. And also because during this time, the skin and all of the tissue that we've replaced in the oral cavity is healing. And our goal is to create a watertight closure before we feed them anything. So that way we prevent any infection, we prevent any food or liquid or saliva going from the mouth into the neck area. So usually after a week passes, if the patient is not radiated and they've had a relatively straightforward and safe hospital course, we will do a swallow evaluation where we will work with our speech and swallow colleagues, and we'll say, listen, how is the patient in terms of, are they able to swallow? And if so, is there any leakage of any dye in the neck? We'll do different kinds of x-rays too that show us that if we've achieved a watertight closure, that any of the dye or the contrast that's used shouldn't go into the neck area. It should go down the normal swallowing passage. And again, this in tandem with the input from our speech and swallow team tells us that, okay, the patient is able to safely swallow, and it does not look like the patient is aspirating or having any kind of a risk of a lung issue. So if that's the case, then we will slowly start them with liquids, and then again, we'll transition them to soft diet. Usually for Dr. Alwani and I, we'll do the liquids for about a week or two, and then if everything is going well, we'll transition them to to soft diet soon after that. And then the second part of your question was, is there a recommendation to eat on the contralateral side? Is there a jaw wired shut? So for fibula free flap surgery, usually, at least at our institution, we don't routinely wire the jaw. It's possible that at some other institutions they may, but with the assistance of the heavy reconstruction bars that we use, all the planning, we've gotten pretty exact for the most part. Again, it's not perfect because you're never going to restore the mandible to what it was before you had cancer surgery, but we can get pretty close nowadays. The occlusion is generally quite good, barring they have teeth. remaining teeth at least. So usually they don't necessarily need to eat on the contralateral side. If the skin paddle is healing and if patients have discomfort, then by all means they can attempt that. But their oral rehabilitation can be multifaceted because sometimes pain can be a part of it. Sometimes just the ability to get a actual swallow bolus down appropriately is part of it. For some folks, months and months later, they may opt for dentures. Some folks may not opt for dentures. Some folks that have teeth, they may have teeth removed in preparation for radiation. So all these things affect what side they eat on. They affect what their diet's going to be, whether it's liquid or soft. But in general, I think once we've ruled out a leak and once we've ensured that they can safely swallow, then we like to progress their diet to a point that they can nourish themselves in a safe and healthy way.
Thank you, Dr. Kadakia. Okay, this will be our last question that we answer. And then if anybody else has anything in the chat, we will actually answer it and look at it and try to answer it for anybody. But Dr. Alwani, this is for you. Where do you see head and neck robotic surgery going in the future? Do you think it will expand to replace other invasive procedures?
Certainly there's additional applications of the robot. Right now we're using it for mainly oropharynx cancers. We're at our institution, we are really pushing the boundaries of what the robot can do. I can tell you that, and Dr. Kadakia will attest to it. I think we're one of the leading centers where we're using robotic surgery for sleep surgery. And this is completely outside the realm of head and neck cancer, but patients with obstructive sleep apnea who can't breathe very well when they're asleep, they usually have obstructions inside the mouth, at the back of the mouth, in the throat. So there's definitely applications that we are seeing the robot really flourish in. We've done some tongue-based reductions, some lingual tonsillectomies, midline glossectomies that have really helped these patients who are otherwise unable to tolerate CPAP machines or otherwise not great candidates for some of the more mainstream obstructive sleep apnea options. So that's one. Recently, we did our first what we call supraglottic laryngectomy. So I'm sure we've, at some point in our medical careers met someone with a laryngectomy. This was a more select patient who had a favorable tumor, who we did a laryngectomy for, left the hospital 3 days later without a trach or a feeding tube, and had negative margins. He is able to talk, eat, and we spared him chemotherapy and radiation. So really something that allows the robot to shine. Once we sort of have, really made our mark on those things, there's emerging literature with regards to using the robot for thyroid surgery. Transoral thyroid surgery is becoming a thing where we pull out thyroids through the mouth, essentially, so you prevent any scarring in the neck. Whether this is less invasive is a question that we can debate, but certainly if you give the patient the option that we're not going to put a scar in your neck that's 6 to 8 centimeters long, and we can provide services where we can see your nerve a little better and we can mitigate the burden of a cervical scar, we're seeing that patients are actually buying into this. This is something that has taken root in South Korea and is now slowly catching up in other parts of the world. There's certainly a few surgeons in the US who offer it, and we're certainly interested in expanding our skill set and technical abilities in being able to offer that. But at this point in time, there's a high cancer burden that we are dealing with, and but I foresee that in the future. So sleep surgery, thyroid surgery, additional applications with regards to advanced tumors in the head and neck. So yeah, certainly more applications to come in the future, and great question. Thanks for asking that.
Thank you, Dr. Alwani. All right, well, that wraps up our program for tonight, and we would just like to say thank you to everyone who attended.
Thanks, everyone. And if there's any other questions, please feel free to email us below or reach out to us. We'll be happy to chat further. Thanks.